going to continue the theme of feet and to bring it back to where I'm comfortable, which is the Arthrogrypotic club foot. This is Arthrogrypotic club feet in 3 flavors. Quick word about arthrogryposis for those of you who don't see a lot of it. It's defined as a congenital non-progressive limitation of 2 or more body parts. So if you've got a child with bilateral club feet, that's not arthrogryposis. But if they have 1 club foot and 1 dislocated hip, by definition, that is arthrogryposis. Sorry, if they have 1 club foot and 1 dislocated hip, right. It's a descriptive term. It is not a diagnosis of itself. We think of it as a sign, not a diagnosis, and it describes these multiple contractures at birth, but it's not telling us what causes them. And it happens in about 1 in 3,000 births. And there's thought to be about 400 different things that can lead to a child having arthrogryposis. So what do all those conditions have in common? Why do they lead to the same problem? It's fetal akinesia, limited intrauterine motion, that the baby for some reason is not moving their limbs the way they're supposed to. And there could be a bunch of different reasons. There can be neurologic, central neurologic reasons, peripheral neurologic reasons, muscular dystrophies of some sort, or soft tissue abnormalities such as Escobar syndromes that can lead to this. But for a joint to develop, it's necessary for the joint to move. And my favorite thing to look at is just the back of your own hand, the little wrinkles that you have on your knuckles. Those happen because intrauterally you were flexing and extending your fingers, and that was stretching the skin as well as stretching the ligaments, getting the tendons to move in their sheaths, and that's why your joints move. And if you don't move those intrauterally, everything tightens down. It's very hard to reclaim that. And these are deformations and not malformations. The joint is initially correctly formed, but because it didn't move, it didn't continue to develop correctly after that. So here's just a case to highlight what we do with these children. This girl, Sophie, here, we saw her before when we talked about the hips. This is her extent of her hip motion. On one side, I'm flexing one hip and extending the other, and I switch it around. So we did our reorientational osteotomy, so at least now she can sit in a normal chair. And then this is the extent of her knee flexion and extension. And we'll talk about this tomorrow, about how we deal with the knees. But here she is upstanding. And here she is a little while after we first got her walk up in KFOs. So what are my credentials for being able to speak about club feet on these kiddos? In fact, I've only written 1 article on our experience. This was almost 10 years ago. And it only had to do with 10 patients. But it actually has to do, I'm just explaining my experience with these kiddos. And in fact, we did a survey of the first 8 years I was at the Shriners Hospital. And during that time, we saw 760 new patients with arthrogryposis. So we've built up something of an experience. At any one time, I have anywhere between 4 and 15 patients with arthrogryposis whose club feet I am casting. And I haven't done any posterior medial releases or talectomies in my entire time at the Shriners Hospital. So what we've learned. First thing is, I look at it as there's 2 types of club feet. There's the classic the talus equinovarus club foot that we have over on the left here. And then we started to realize that there's another kind of club foot variant that we call the equinocavus foot. That's in the middle. And of course, the congenital vertical talus. So these are the 3 types of foot deformities we're going to talk about today. So starting with the classic one, it's the most frequent foot deformity. And it's more severe and rigid than idiopathic club foot, probably, again, because whatever the abnormality causes these club feet, it happened earlier in pregnancy, so they're doing less motion, and things got stiffer. And of course, our hopes are to take a pair of feet that look like these and turn them into those. And actually, if I look at these now, this is actually quite simple now. The harder ones we'll talk about in a little bit. The goal is to end up with a braceable foot, one that is flat to the ground, that makes a good platform. Do this with the least amount of surgery and hopefully the least chance of recurrence, but especially burning no bridges. This is an algorithm that was published just over 20 years ago about treating arthrogrypotic club feet. And on the left is where you want things to go. You cast them, you do surgery back then, and you end up with a good result. But the problem is a cycle. There we go. The cycle over here. This is where the big problem is, though, because you do your surgery, you cast them, they become unsuccessful, you get a recurrent deformity, you cast them, you get to the point of saying, okay, you do surgery, a bunch of different choices, all which are bony procedures. There's some papers out there that show that if your first procedure is soft tissue on these club feet, the second one is going to be bony, and they become more and more ablative. And you can see at the bottom here, you go anywhere from fair results down to poor results. And how often does that happen? Well, 73% of the time this happens. So it's a lot of recurrences that end up with bad findings. And this is what you really want to avoid. This is a patient that sent to me. I had no idea what bones were still left here. A lot of them had been taken out and coalesced together. And I ended up having to fix them with multiple osteotomies and an external fixator. So we kind of devolved into the modified Ponseti method. So the Ponseti method, of course, is using forefoot abduction to gradually correct the foot across the talus, using the lateral head of the talus as your fulcrum, and then doing percutaneous Achilles tenotomies. Now, part of what we'll talk about is that usually in the Ponseti technique, that's the last thing you do. Here, sometimes it's the first thing you do. And then, of course, bracing. So what are our modifications? Well, the ankle contracture can sometimes be quite severe. And what happens is the calcaneus gets locked to the backside of the talus, and that's why you can't get your correction. And early on when I started treating these feet, when we were told that, even Ponseti said that this was not the right technique to use for arthrogryposis, to give ourselves confidence, we started to do an initial Achilles tenotomy. Now I've gotten to the point that I rarely do this, but for anybody who's got a contracture of about 40 degrees or more in equinus, I'll do an Achilles tenotomy early on to help with the correction. But for anybody who's starting off treating arthrogrypotic kiddos, I would say this is a great way to do it, to do your Achilles tenotomy first, and then do your correction, and maybe doing another one at the end. Nowadays, sometimes we'll do a few casts and then do an Achilles tenotomy just to get the story going. But here's a child, just as an illustrative point. Severe contractures there. You can see what he looks like. So here we're injecting our local anesthetic, and they were doing our percutaneous Achilles tenotomy. And here you can see immediately after the Achilles tenotomy how much correction we're able to do. Not that we're dorsiflexing him, but we're able to swing that heel out of varus. And then there is our first cast. You can see what a correction we got there. Here's a child, multiple procedures before he came to us. So we start with a few casts just to loosen things up. I sometimes worry about telling people about doing this because they'll do a few casts, not achieve anything, and instead of going just to an Achilles tenotomy, they decide that they're just going to abandon ship and go for a full-out procedure. And that, I think, is a shame. The other thing is if you have a very rigid ankle, if you do a lot of casts, you can end up with some skin problems or cause a midfoot break. But again, if you're comfortable with this technique, doing a few casts just to make it a little easier to access the Achilles and then do your tenotomy works quite nicely. So for nowadays, I'll do it if the correction reaches the plateau. Here was a child who had 13 casts done elsewhere. They decided this is a point where the child required a full release, and we just did a percutaneous tenotomy. You can see how far that got us, and it was just another 3 casts after that. We had a fully corrected foot. It's important to remember that the toe flexors are oftentimes very tight, and they can cause you as much trouble as the Achilles itself. So you need to slowly cast those out. It's very painful. This seems to be one of the most painful things for the children to have, is getting their toes stretched out. So you need to be a little bit slow about this. But also realize that if we don't completely correct them, the toe flexors can be the thing that jumpstart a recurrence, because the toes will bend down, and that actually causes everything to curl in. So our second modification is how we get our counter force. So if you know the Ponseti technique, you put your thumb over the lateral head of the talus, and that's what you're pushing the whole foot against. That works well in babies because you don't have to push too hard. You do it in an older child with a stiffer foot, you will get a skin impression there that will cause skin breakdown. So we rapidly decided we had to do something else in order to control the talus. And so we use the ankle to control it, figuring that, of course, the talus is sitting within the mortise, and because of that, the talus is held constant within the mortise. And what we can do is put the flat of our hand on the anterolateral aspect of the ankle, like I'm doing over here on the left. Or sometimes even just saying, well, I'm not even going to worry about having a hand around the ankle. I'm just going to rotate the foot, expecting that the tibia is not going to rotate on the femur, and so I can actually rotate the foot around in the ankle and use that to get my stretch going. Now, it sometimes helps to do a little 4-point bending to try to loosen up the foot a little bit. So I'll put a thumb right on either side of the tail navicular joint with the fingers of one hand coming around the ankle to the heel, and the fingers of the other hand getting the medial side of the foot. So it looks something like this. Got a thumb here right over the lateral head of the talus. Have another thumb going onto the navicular on the lateral side. And then by slowly trying to shift over, you can actually feel with your thumbs, you can feel how the talonavicular joint is sliding over laterally. And this helps when you've done several casts, things are coming along, but you feel like you've plateaued a little bit. Doing a little bit of this stretching can sometimes make a big difference, and it's not that uncomfortable for the child. It just gets things to kind of move over a little bit more. So here's a child, 3 years old, no previous treatment. You can see he's been walking on these club feet. That's what they look like when you look straight from the front. So here we did initial tenotomy. We did 9 casts, and then the final tenotomy. This is what he looks like now. Now, he's had a number of relapses, and we'll talk about relapses in a little bit, but we've always been able to keep him walking on his feet. And he is now 6 or 7 years past this point, and we have not done any major operations on him. Here's a boy. We were told he was 10 when he was adopted from China, but he's probably like 12 or so. They told a younger age to make him more attractive. But he had a number of procedures on his feet, never been able to walk on them. This is what his feet look like. You can see the scars on in the middle picture there. And this is after several treatments here. So we did 5 sets of casts, and then we did tenotomies on both sides, and then another 5 sets of casts. They lived several states away, so we weren't seeing them on a regular basis. So it took about 5.5 months to get this all the way corrected. But we were able to get him corrected out fully, took care of his hips and his knees, and he's now walking with crutches. 9-year-old child had previous surgeries as well. This is what her feet looked like when we first saw her. And then again, we did 8 sets of casts, tenotomies, another 8 sets of casts. So it was 16 sets of casts, but we got her feet plantar great. Now, what you'll also notice in the upper right picture is a lot of external torsion of the, or external turning of the feet, which I will tell you is external torsion. And I kick myself about this. It took me a long time to realize it, that a lot of these patients have external tibial torsion. It's not what we usually think about with club foot, but a lot of the arthrogrypotics, for whatever reason, ankles are turned outwards. And I think this is also why we have difficulty with some of them maintaining control. You get a pretty good correction, and it comes back very quickly, because we keep on thinking that the ankle's pointing forward, but it's actually pointing out east and west. So here, for example, if you notice the top of this picture is an AP of the knee, but the bottom is a lateral of the ankle. And so here, we do a derotational osteotomy, and we get things to line up appropriately. Or same thing with this child here, who's got a severe knee flexion contracture. And so in her case, you can see on the right pictures here, you still see my pinholes from the Alizaroff frame. So we did a derotational osteotomy at the same time we put the Alizaroff on to straighten out her knees. My procedure for doing this, just real quickly, is in the operating room, I'll get a true lateral of the ankle under fluoroscopy, and I'll put a Steinmann pin in the sagittal plane of the ankle so that I know where the ankle should be pointing. You see here it's about 50 degrees or so turned outwards. And I'll make a medial incision, take a 4-hole plate, put the proximal screw in, drill the second screw hole, and then swing the plate out of the way. Like you see there, there's my second screw hole there. And then make a transverse osteotomy right below that. Very rarely have I found that I need to also osteotomize the fibula, even with 90 degrees of external torsion. The fibula just kind of seems to go along for the ride. And then derotate things, put my last 2 screw holes in place, and that tightens everything up. And it's about a 20-minute procedure or so if you do it that way. And that's worked out pretty well. When I first started doing these, I got a little nervous about correcting them to anatomic. So I do a little bit short of that, and now I have reason to be very unhappy about that because those are still recurring. Whereas if I correct them to anatomic, usually it takes a year before I want to take the plate out. I'll do another set of casting at that point and get the feet back to where I want it. Quick word about talectomies, because the literature talks a lot about that, both as a primary procedure and as a salvage procedure. But if you take a good look at the literature, really look at the whole timeline, there's a high rate of tibial calcaneal fusions, as well as you lose medial column support. So you end up with a lot of procedures that say, oh yeah, this is a great primary procedure, but if you follow it up, you only have about 50% satisfaction rate with that. And the times where you have issues, they are big issues. A child sent to me, she had a talectomy done. When it ended up in equinus, you can see somebody tried to correct it with an osteotomy and continued to go into equinus. So she requires a second osteotomy to get her feet flat. Here's another child, same thing, had a talectomy done, and is gone to equinus. So again, procedures needed to correct that. And interestingly is that some of these kiddos, this child in particular, when I first saw her, still had some motion at that pseudo joint that you create there, but it fuses over time and tends to go into equinus or also into adductus, a very difficult procedure, difficult deformity to correct. I want to talk now about the second form of clubfoot, the equinocavus clubfoot. This is distinct from a regular clubfoot in terms of there's not a lot of supination or adductus, but there's a lot of cavus. And the cavus, it goes all the way across the foot. There's a crease that goes from medial to lateral. And it took us a while to figure out that this is a different kind of clubfoot. So the whole idea of casting is being able to get the foot to dorsiflex and to resolve the cavus to get the foot nice and flat, like we're seeing here in these pictures. And then we continue to brace them after that. The toes tend to be quite tight, and it's not unusual that once you get the foot corrected, that the parents will complain because the toes keep on kind of curling under the foot, and they may need tenotomies in the future. The treatment for this actually comes to us from Dr. Ponsetti again. Remember, Dr. Ponsetti used to talk about the complex or the atypical club foot that sometimes would just happen by itself, sometimes would happen when a child slipped in a cast. And he would talk about the four-finger correction, where you put your fingers over the dorsum of the foot, your thumbs over the metatarsal head, and you dorsiflex the forefoot in relationship to the midfoot. And that's the same thing that we do here. So dorsiflex the forefoot relative to the midfoot. You do little to no abduction, and you need to remember to stretch the toes. The part about the abduction is very important. Before I realized that this was a different kind of club foot, and I'd use regular Ponsetti on it, I'd end up with these feet that were in horrible abductus, and they just stay there, and it almost, it looks like one of the worst flat feet you've had. It's very hard to correct that over. And you delay the Achilles tenotomy until the cavus is fully corrected. What's nice about these is once you recognize these and you treat these seem to have a lesser reoccurrence rate. They have the toe flexors get tight, but the feet themselves hold a nice position. So here you can see how we kind of correct these out. Another foot that we corrected out. Here's a 16-year-old. This is before, never had treatment. This is what her feet looked like when we started. Here we are, 9 casts in. You can see it's a little bit tough on the skin because she's quite stiff. And here she is right before we did her tenotomies, and unfortunately I was dumb enough not to get pictures after doing tenotomies, so this is before tenotomy, but we got her plantigrade as well. So about bracing, this is the typical brace that we all know that we do for idiopathic club feet, but it doesn't work for arthrogrypotics by and large, and that probably has to do with the fact that arthrogrypotic kiddos are not kicking like idiopathic kids are. And also, when you have the hip and knee contractures, it's hard to fit these kind of brace on them. So early on, we started using what I call a dual-purpose AFO. So it's an AFO with a leaf spring that uses a solid AFO during the day. And at nighttime, we put these dorsiflexion straps on to try to dorsiflex the foot and to evert it. So the lateral side is tighter than the medial side to evert the foot. A quick word about the anterior tibialis. There's the occasional case where you'll find that the foot is not correcting out because it remains in supination. And sometimes what you need to do is a little percutaneous tenotomy across the anterior tibialis there. In terms of recurrence, very common, regardless of how you treat it. If you treat it with casting, if you treat it with surgery, recurrences are common. The important thing to realize is if you do casting, you can cast them again. In fact, if you get recurrence after surgery, you can cast them. But not to say, I've got a recurrence, it's now time to do surgery. I now tell parents of new kids, we're probably going to be casting your child every 2 years until they get someplace into the 5 to 8 year range, and then the feet seem to stabilize out. And if we have any deformities left, we might do a sliding calcaneal osteotomy or other procedures to get the foot flattened out. But these are smaller procedures, and we're not going to cause a lot of trouble with that. Another particularly important topic to understand is the children who have the straight knees, who are born with the congenitally straight knees. It's easy to mistake the bump that you feel over there as being the patella, but in fact what that is, it's the medial femoral condyle. And if people take that to be the front of the knee and they stretch it out, they end up with this terrible valgus deformity that you see here. So that smiley face is actually the front of the knee there. So we want to stay away from that. Make sure that people understand where the front of the knee is when they stretch out these knees. Excuse me. Then I move over to the congenital vertical talus. This is a third deformity that we have. This is a relatively rare deformity, but one of my friends, Matt Dobbs, has seen a lot of these and was very smart to come up with a way to treat these. So we all know about this. Oh, is that my time? Okay, I'm almost done. Congenital vertical talus has equinus, hindfoot valgus, midfoot is in planus with the talar head palpable in the midfoot, and we also have abductus of the forefoot, which makes it the exact opposite of a clubfoot, other than the fact that they both have Achilles tenotomies. Number of muscles in the anterior lateral side of the foot that are tight. How do you define a congenital vertical talus? Well, the talus is not only vertical with the head pointing down, but the navicular is also dislocated onto the anterior portion of the neck there. And it doesn't reduce when you try to plantar flex them. You don't get the navicular to come back down to the head of the talus. And you can also look at the axes of the talus and the calcaneus. You look at your Keitz angles. You look at the axis of the medial foot and find that doesn't line up with your talus. This is a number of photographs I was very proud of when I did it early on, when I took a whole foot apart and put it back together again. And now I realized that was just the wrong thing to do. Dobbs came up with this technique, published in 2007, which really works very well, makes a lot of sense. And the whole idea is that you're stretching the foot into plantar flexion, supination, and adduction. And then you stretch out all those anterolateral structures, the peronei, everything else, and get the foot to correct over. In Dobbs' hand, where he looks at idiopathic congenital vertical talus, you can oftentimes get the tailnavicular joint to line up. In my arthrogrypotics, I've always had to go and actually do an open reduction of the tailnavicular joint. But just to see how well that casting does in correcting out the foot deformity, this is 4 casts to go from what you see on the left to what you see on the middle and the right. Or this one here, parents sent me this one. They were taking x-rays or photographs every visit, and you see how in 3 casts we got these feet to look that much better. They stretch out so much faster than a club foot. And then what you need to do is a small incision. It's about 2-3 centimeters right over the tailnavicular joint. Reduce the talar head onto the navicular and pin that joint. And so it looks something like that. That's our incision. There's our pin. And things line up nicely. So this is what the patient looks like. So conclusion, foot deformities occur a lot in arthrogryposis. They can be treated well without extensive surgery. It just oftentimes takes perseverance to do that. In the older child, you might need to do some nipping and tucking to get the foot to line up well. But really, serial casting is the way to go. Thank you very much.